Welcome everyone to our Navigating Neurological Conditions webinar. I'm so glad you're here. I'm your host, Genny Jessee, and I'm a mom of a medically complex child and co-founder of the June Jessee Memorial Foundation. I am on a mission to make lives easier for children with medically complex neurological disorders and their families. Thank you for taking time out of your day to be here. Our guest today is genetic counselor Erin Beaver. Erin earned a master's degree in genetic counseling at the University of Arkansas for Medical Sciences and has 9 years of clinical experience working with families as a genetic counselor, with about 6 of those years being specific to pediatrics and neurodevelopment. Also joining us today is Allison Reichart, a June Jessee Memorial Foundation team member. Allison will serve as moderator of our discussion today. Today, Erin and I are going to talk about how genetic counseling can be helpful to families with medically complex neurological conditions. Welcome, Erin, and welcome, Allison. Erin, first of all, I want to thank you so much for joining us today to share your knowledge and experience. When we first saw a geneticist and a genetic counselor, it was all so new and confusing for us. And one reason for us seeing a genetic counselor was twofold. We were trying to get a diagnosis for June, of course, but we were also trying to figure out if and how to grow our family. And I know many parents in the JJMF community can benefit from the help of a genetic counselor in various ways. And I'm so glad to bring this opportunity to them to shed more light on the subject.
So Erin, just to start, could you tell us a little about what brought you to the field of genetic counseling? And can you share a little bit about your experience working with families?
Yeah, so actually I got interested in genetic counseling when I was in high school, and my math teacher at the time, I was babysitting for her. She had 2 children, one of which was a little girl who ended up developing seizure disorder and having some developmental delays. And there were a number of years there where she was becoming medically complex. Her seizures were uncontrollable, and they just really didn't have a good answer. And I lived in a rural community, so we didn't have a lot of access to specialists there. But it did take, I think 2 or more years for them to actually get connected with a genetic counselor. And when they did, that's when they got their diagnosis for their daughter, which was Angelman syndrome. And I got to see from perspective of a community member, but also somebody who was helping them care for their children. I got to see how having a diagnosis affected their lives, and it was very positive in my experience. And I thought, I love science, I like working with people, and I think that this is really the place where I would grow and thrive and like to be, how I'd like to contribute to the world. So that's what originally got me interested. But it was amazing to watch how nothing changed about their daughter, Leah, but what did change was their understanding of how best to help her. And so I think having, the diagnosis that happened to be genetic did a lot to empower their family to move forward. And then, now I've watched Leah grow up, and she's in adulthood, and watching their family transition through that, and just how well that they've done has been amazing to see. And so they continue to inspire me. But that's what originally got me interested in genetic counseling. So I'm excited that then I got to spend 6 years and now more, hopefully many more, working with families that are like Leah's family and helping them to find answers. We don't always find answers, but when we do, it is really great, and it helps the families out a lot. I think that as far as my working experience, I've been able to come to genetic counseling in a lot of different ways. So I started out in a prenatal setting, and I got to experience what families go through in a genetic prenatal setting, what kinds of answers that they're looking for. And then I came in and was doing a lot more pediatric care and some cancer care. But in the pediatric world, I got to work not just in a general genetics clinic, but actually also in an autism clinic, where the children that I was seeing were primarily neurodevelopmental diagnoses that they had. Sometimes seizures, sometimes more medical complexity, sometimes less. So I've got to experience a lot of different perspectives from patient care, from families, and what they were having to deal with on a day-to-day basis. and the needs that they had.
I think your personal connection is so interesting. And I think going back to what Genny shared with her personal experience, she talked about how seeing a genetic counselor helped her family navigate the question of how or if they would have more children. How do you help families who are considering adding more children to their family?
That's a really good question. So I first want to just acknowledge that when we're talking about children who have neurodevelopmental diagnoses, that we're talking about a very wide spectrum of children. And so some children are neurodevelopmentally complex or neurologically complex, like seizures. And then we have some children that have that, plus they have some more medical complexity. And so that's a lot of different kinds of experiences again. And even within that spectrum of what we're talking about for clinical features, we still have families that have a lot of different belief systems, a lot of different personal experiences, and not every family feels like they need to seek information about diagnosis in order to build their family. And so I just want to acknowledge that, but there are families who do want that information. And I have worked with those families in the past. And I think that there's a lot of options out there that maybe will fit in with different families based on their belief systems and their experiences. So what I would say first is that you can do genetic testing, and that can be at different points in time. So sometimes families will seek genetic testing very early because they're looking for answers for the treatment for their child. And through that, maybe we find an answer that also helps them with their family planning. But sometimes families do seek information from genetics perspective just for family planning purposes. And when we are able to get a diagnosis for them, we find, through that we can give information about what are the chances that this could happen again. And when we're talking about these different disorders, there's different inheritance patterns is how I would put that. And so we might say, okay, we found something for this child, and it's something that neither mom nor dad had, at least in the cells from their blood or the cells from their cheek swab. And so presumably there's a very low chance that this would happen again, less than a 2% chance. Maybe we find that mom and dad each carry something, and that those two things came together in a child, and we would say, okay, there's a 25% chance for this to happen again. So for some families, when we find an answer, we're able to give them very specific information about the chances for recurrence. Some families will just take that and use it to decide how they're going to build their family moving forward. Maybe they still intend to use a natural conception and go from there. Test maybe when the baby is in utero or after the baby's born, if they want to know that information. So that's one option. Another option is that some families may want to do what's called PGD, which is where that they would prevent a pregnancy from being affected. And how that works is that you would pair in vitro fertilization, so having a conception outside of the body, and we would test those embryos to see if they're affected by whatever the genetic condition was that was identified in the older child. And then we can know, okay, which embryos are affected and which ones are not. And they would only implant back those that are not. So that's another way that people may use genetic testing information in their family planning. For some families, they may say, okay, we want to use an egg donor because maybe this is something that is X-linked. And so rather than go through PGD, maybe they want to just use an egg donor. Some families may say, maybe we want to use a sperm donor because maybe it was something that came from dad's side of the family, or you can use a gamete donor either way if both parents are carriers for something rare that's recessive. So some families do choose to use gamete donors, but again, different people have different belief systems and different feelings about that. So that's not maybe the right choice for everybody. But these are some of the ways where we can still create a conception, and we're using that genetic information to help to sway the chances that this would or would not happen again. There are families who do not get clear answers from genetic testing. we have probably 20 to 25,000 genes. We can offer testing for 5,000 to 6,000 genes, and maybe around 2,600 or more of these days have been associated with neurodevelopmental differences. So there's a lot that we know, but there's still, when you think about it, a lot that we don't know. And so our testing has come a long way. It's really great. We think we cover the genes that we know about at least 98 to 99%, but that is still not 100%, right? And so there's still a lot of room for us to not have answers, even when there is something genetic going on. So for some families, not having an answer, they can say, okay, we've ruled out the stuff we know about, and we're just going to move forward. And then there's other families that say, well, I need something more clear than that. And so that can be a hard position to be in. And I do think that it does, in that circumstance, take a little bit of moving forward with faith, whatever that looks like for people. And it does look different in different families, right? But there is a certain amount of faith that has to go into, we hope this doesn't happen again, or we've dealt with it once and we can do this again, sort of a situation, and families move forward that way. But there are some families where that's still just not the right answer for them. And there are other ways to parent, of course, and I do want to highlight those. So adoption is always an option. From a perspective of there are children here to be adopted. Of course, that does take resources, and that's not something that every family may have. You can do foster to adopt, which is another great option. And then, I think, again, reiterating the donor situations. Now I know that everybody has, again, different beliefs and different feelings around biologic versus non-biologic, but those are options that are available to families. And then I guess the last thing that I would point out is that some families go through an experience of having a medically complex and neurologically complex child, and they say, you know what? I feel like I was able to really do justice for my child, and I feel empowered to be a parent to other kids who are like that. And so they will go and purposefully adopt children who have those neurologic differences in medically complex cases. And I think that, we've kind of gone around the full spectrum of how people build their families in these circumstances.
Yeah. I know for our personal experience, as June was undiagnosed, and Matt and I, my husband and I, we really wanted other kids. Even before we even had June, we knew we wanted to have more kids. And that was something that we really wanted to do. But before we had other kids, we wanted to make sure we checked every box, tested for everything. Before we had George, we waited till we got all of our test results back. And, before we went that extra step. And then after that, we said, we just took a leap of faith. We were told that at best, it was 1 in a million chances that it could happen again. And then at worst, it was 1 in 4. And I remember another mom in a similar situation always said, odds are in your favor both ways. So we just kept repeating. I just kept repeating that to myself over and over again. Even at the worst, 1 in 4. I mean, it was still odds were in my favor. And that's not to make light of how hard but like you said, it's difficult. It's each family's value systems and what they can handle, and what they, how much level of faith or risk they're willing to put into it. So.
Right. Yeah, that's exactly right. And I think what you said, that mantra of kind of flipping the numbers, that's something that is important, and something that I try to point out to my patients too, because, you can be seeing that recurrence risk number, and that's the only number, and it becomes, your whole world and how you're making decisions. But when you flip it, it's funny how sometimes it can change your perspective.
Yeah. Yeah. And I remember saying to myself, because that is a question a lot of people ask me, is you went on and had George and Peter after, how did you make that, how did you decide to have it? How did you make that decision? And with not knowing, and I mean, everybody who has a baby is at whether, like, let's say we would have had George and Peter first and then had June last, like I wouldn't have known my level of risk before. Like every person when they have a baby it's just whether they're aware of that risk or not. So it's like, I was just more aware of it and like being comfortable in that unknown. So it's just like everybody has some potential form of risk when they have a baby, I think.
Yes, yeah. So I mean, there's the background risk for any child that's born to have, a medical condition or a neurodevelopmental condition. So that's not a small percentage.
Yeah.
But when you flip the numbers, you think, well, the vast majority of the time, things like that are not happening. But even when we adopt a child or use a donor, it does not guarantee that there's not going to be any kind of medical complication now or in the future, because any child is at risk, not necessarily even for genetic issues, but for other things that can come up in life that could affect them medically and developmentally.
Yeah, definitely. And one thing, and I do know, and I have met people who have a child with severe medical complexities, neurological disorders, and then they go on to have another child, and that other child does also have, and I just think it's like both those kids are loved and a valued member of their family, and they're like, obviously this isn't a path that anybody would choose, but I do know that when it has happened twice to families, that they are so loved and so like just as much as any member of their family would be. So
well, there's so much complexity to the question regarding family planning. I know every situation is unique, but I also know that's not all you do in your career in genetic counseling. So can you share with us some of the other benefits of genetic testing outside of family planning?
Yeah, so which is a great question and a great point. So like I mentioned at the beginning of the question about family planning, some families seek genetic testing because they're looking for a diagnosis that could affect their child's treatment. And we do have some diagnoses related to medical complexity, neurodevelopmental complexity, where there is something we can do about. There's a treatment that we can offer. So I would throw into that metabolic conditions, which we're going to talk about, I'm sure, a little bit later in more detail. But metabolic conditions are an example of treatable differences. We're beginning to get into a realm of, I guess, the part of medicine where we can actually do something about genetic disorders. So there are some gene therapies that are available now. That's very new and they're very few, but there are some. And that's only going to increase in number as we move forward in time. So there are some things that we are going to be able to treat. Some things we can treat now, some things we're going to be able to treat in the future. There are some what we call storage disorders, which have enzyme replacement therapies. And those, there are effective treatments for some of those conditions, although there's some limitations to what symptoms that they can and cannot treat with that. But yeah, I mean, there's a good reason to seek genetic testing just for treatment purposes alone. I think that another good reason why families seek genetic diagnosis is to understand what the future might look like. Or to find community. And I kind of group those together because what I mean by that is that if you are able to identify a diagnosis, then you might be able to find other families in your community that are dealing with that same diagnosis for their child and have had maybe some similar experiences. And so you can build more specific community in that way. The other reason why people may try to get information is because they want to plan for the future. So we talk about family planning oftentimes in the sense of building your family and adding to your family. But family planning also does include, having a lifelong plan for the care of a child, especially a medically complex and neurodevelopmentally complex child. And so kind of getting an idea of what level of ambulation, for example, will my child maybe be looking at? Not that we can ever, we don't have a crystal ball. So our genetic diagnoses are never a concrete, like this is exactly the story that this child is going to have. Every child is their own story. And, they are going to accomplish things that nobody would have predicted. They're going to have their own strengths and weaknesses that have nothing to do with their genetic diagnosis. That's just part of their story. So, all that to say that this can help us to have an idea about what the future might hold, but it's still, it's still fluid. So some families want to know, do I need to start financially planning for my child to have security and resources? Are they going to require, a certain level of medical care and assistance? And, lifespan is a conversation that does come up for families. And a lot of families may be worried about, well, as a parent, if, I'm going to get old and I'm going to pass away one day, and who's going to take care of my child that's now an adult? And what do I need to do to prepare for that? And then I think also, acknowledging that there is going to be a point in time where some neurodevelopmentally complex children are going to be out in family planning on their own. And as uncomfortable as many parents are, I think, with their children and talking about family planning, especially if they have young children right now, that's an uncomfortable conversation, but I think sometimes it's even more so for families that have a neurodevelopmentally complex child. So, but that is something that comes up. That is a question that many adolescent children will come up with. In clinic, I get asked that question by teenagers a lot. And so that's another reason why we might want to do testing is for that.
That brings up a great question. I think sometimes there's a misconception that all genetic conditions are inherited. And we know that's not always the case. Can you talk about why that isn't always true?
Yeah, so one thing that I would point out is that anytime the cell is growing and dividing, there's a chance for a mutation to happen in a gene. And so there are some individuals who have a genetic diagnosis that they did not get from their mom or dad because there was maybe a mutation that happened in the egg cell or sperm cell that produced them. Or at some point in their embryologic or fetal development, there could have been a mutation that occurred, and then all the cells that came after that have that same mutation, and that's led to their genetic condition. So those are things that can happen that we call those de novo mutations, or new. That's just a fancy way of saying a new mutation. But that's what that means. Methylation errors are another very common group of neurodevelopmental. They're not all neurodevelopmental, but there's a couple of them that are, and those are not inherited. So what we mean by methylation, they are epigenetic conditions. So it has nothing to do with the sequencing of the DNA, but rather with groups that are added to turn certain genes on and off at different points in time. And that's reset in every new generation. So that happens very early in embryologic development, but it's not something that was inherited from mom or dad. And Angelman syndrome is actually a good example of that. So you can get Angelman syndrome in different ways, but one of the ways is from a methylation difference. And so, this is not something that is inherited from mom or dad in that way. It was just a resetting of methylation groups. And we don't understand why that those methylation groups don't get set correctly in those examples. It's just what we see, and I think over time, maybe we'll understand that process better. I also think we'll probably identify more conditions that are those epigenetic conditions. So those are examples. Another thing that I would point out, which is just an interesting kind of perspective, and there's probably more conditions like this that, again, we don't understand, but there's a condition called maternal PKU. PKU is a metabolic condition, and it's recessive, and a mom can actually have that. And if she's not being well managed, it can, during a pregnancy, cause that child to have neurodevelopmental differences in the long run. So when the brain is developing in utero, if it's exposed to the really high levels that go along with untreated PKU, then that can cause that child to have a neurodevelopmental neurodevelopmental, phenotype, what we call it, or presentation. And then again, it wasn't something that was, it was kind of genetic because mom had a genetic condition that wasn't being treated or maintained, but it's not inherited. That child doesn't have PKU. They just have the symptoms that can go along with it.
And speaking of that quickly, one thing, can you talk about briefly how, like, how some viruses that maybe a mom would get while pregnant can, does that affect, like a popular one is ZIKA, like how does that affect the genetics of the baby or just the development of the brain?
Just the development of the brain, but those are really good examples of what we call teratogenic effects. So things that happen when a baby is growing and developing that can affect, the long-term medical, or in this case, neurodevelopmental aspects of that child. So ZIKA, it is affecting the brain. We don't understand how specifically that the virus does that. It does cross into, through the placenta into the amniotic environment. There's not all viruses do that. So I'll point that out. Some do, some don't. So ZIKA, though, is an example where you can get microcephaly, which is a small head size. And then also you could get things like seizures or neurodevelopmental differences, and it can mimic genetic conditions. So it's not genetic, but it can mimic that. And there for a while, when we were first dealing with ZIKA and understanding what it could cause, there was a lot of, because microcephaly is a reason why a child should get referred into genetics, but there was a lot of like a screening for, could this person have been exposed to ZIKA? The mother or father, because it actually can transmit from one partner to another, they found. But yeah, that was the big question. And I think that, we haven't had, well, now we're dealing with COVID, so we don't know exactly, how that affects kids long term, but I'm sure we'll hear about it at some point. But ZIKA fell off the map a little bit whenever, we were dealing with a global pandemic. But it is something that we do have to consider. And when we are doing genetic evaluations, especially on infants, it is a question that comes up, and it's not just ZIKA. There's other viruses that are very common, like CMV, cytomegalovirus. Some people who are not maybe vaccinated against rubella, that's another example of a infection that can cross the placenta and cause birth defects to a child. So there's many examples of that.
And the hard part about that, because I remember with June, because June had microcephaly too. This was pre-ZIKA. But she wasn't born with a small head. Her head just stopped, her brain just stopped, her head was normal size, and then just her head just wasn't growing, her brain wasn't growing. But the hard thing about that is, like, one thing the geneticist said to me was it was possible that I got a virus while I was pregnant, but there's no way to confirm that. Like a year later, the only way to confirm that would be there's just no way to tell. So it's kind of like, and usually it's only if you get CMV for the first time while you're pregnant, so that, and like, we didn't test viruses back then, like we are now. I at least, like, if I had gotten a cold, I wouldn't have been like, do I have CMV or, so I don't know. It's just, that's what's hard too.
Yeah, that's, occasionally they have this panel called like a torch panel, which when we see birth defects in utero, then oftentimes they'll offer that panel to a mom, but to test for, those common viruses. But it definitely is not exhaustive of all viruses that could potentially have teratogenic effects. And if we don't see anything on an ultrasound, which is the vast majority of cases where, birth defects happen, we can't see everything on an ultrasound. So then we don't even have the opportunity to offer that. And you're right, it's a moment in time that you have to capture to understand if that is an effect for that child's health or not. And unfortunately, looking in retrospect, there's nothing that you can do if you didn't have, that captured at that time. It can be hard. There are some, so in the way of cytomegalovirus, if we suspect that child may have that at birth, then we can test then. And it's possible if they were exposed earlier in pregnancy, within a certain time frame, we may be able to pick it up. They also can look at the back of the eye through like an ophthalmology exam and see some evidence of infection there too. But again, that's still just like a very specific window. And you're right, when you get a year down the road, we can't say for sure. We can say this is a possibility, but we can't ever rule it out.
It's so interesting. There's just so many different things to consider.
Yeah.
One of our JJMF community members actually had a really great question, and she was wondering about the importance of food and diet in recovery and how that may affect genetic conditions in any way. Will you share your thoughts on this subject?
Yeah, so there is some overlap or some interaction between our dietary intake and our metabolic functioning. And so there are some genetic conditions that we call metabolic conditions. Most of those are recessive. Some are X-linked, but I would say by and large, they are recessive conditions. And we can actually treat those conditions by dietary changes within a certain extent. So we can never get rid of all of the symptoms for some of these conditions, but we can optimize outcome and maybe in some ways actually prevent, like for PKU is a great example where we can actually prevent some of the neurodevelopmental differences that happen with that. There are metabolic conditions and diet is important to those. And maybe it's not necessarily just food. So with PKU, the proteins are a big deal. And so they contain a compound that these individuals cannot process, and it allows toxins to build up. So we can actually prevent the neurologic damage that happens during the brain development in early years by really controlling the diet in that time frame. And you have to be careful because obviously there's some things that our bodies need to grow, but we don't want to, in this circumstance, have too many toxins because of these missing enzymes and causing us trouble with the neurodevelopment in the long term. So we have to be very careful with that. Another thing that I would point out is that there are conditions where it's not necessarily you're controlling the intake of the specific foods, but rather that you're supplementing with certain vitamins that may be deficient. And that is what treats the metabolic condition. So there's those as well. When we have maybe talked a little bit about mitochondrial conditions, but some families do find that you can optimize outcome with mitochondrial conditions by using a vitamin cocktail is what they typically call it or refer to it as, but it's another one of these where you're supplementing with specific vitamins, but you're not necessarily like saying, oh, you can't have steak or, potatoes or something like that. It's like a supplement that you're changing. There are kiddos, I would add to this conversation, that have seizure disorders, which have been successfully treated, not with medication, but with a ketogenic diet. And these are usually kiddos where they've tried lots of different seizure medications and have had no success in controlling that. And they have found that this ketogenic diet does work to control seizures for some patients. There's some very specific genetic conditions that fit into that group of patients. And then there's some that are not very specific genetic conditions, but just uncontrolled seizures in general. I think that at that point, we feel that we can't do any harm. The seizures are already doing enough harm. So what's, changing the diet a little bit isn't going to be an issue. And if it helps, great. If it doesn't help after a certain period of time, then families just go back to a normal diet. But it is a lot of work to change, a child's diet, because that really does impact the entire family if you're actually talking about food intake.
Yeah, we did the ketogenic diet with June, but it was actually very easy because she had a formula that was already just done. But I feel like that's the only time to try. I mean, well, obviously you would try it at other times, but it was an easy time to try it because it's just like the formula.
Yes.
But so it doesn't actually turn off, the diet doesn't turn on or off certain genes. It's not affecting we don't know.
We don't know. So we don't totally know. And I think that a lot of when we're talking about metabolic conditions, you're either controlling things that we know can't be processed with the hope that if you don't have an abundance of that thing, then you can't have an abundance of the products that are byproducts of that are causing the trouble. So that's one thing that we do know. The metabolic conditions where there's a vitamin deficiency and we're supplementing with whatever that enzyme or vitamin deficiency is, then those, I mean, we are supplying that. Their body can't make it, but we can supply it to a certain extent. And so that's how you're treating that. But yeah, we don't understand how the ketogenic diet works. And definitely I have heard families talk about, and I trained in a autism center in my master's program, where one of the physicians felt very strongly that things like dyes were affecting children's behavior. And was it that they couldn't process through that, or what, we don't know. I don't think anybody has a good sense of what it was that was causing behaviors. But I think about how when I get a hold of too much caffeine, that affects my behavior. While we understand the cycle and like the metabolic process of caffeine, there's probably a lot that we intake in our bodies that we really don't understand. So I can't say why the ketogenic diet works for some families, and certainly I think that when families find that there's triggers in their child's diet and they want to avoid those, I support that. As long as a child is getting nourishment that they need to grow and thrive, that's the important thing. But if families find that there's, something that's causing a trouble for behaviors, is it a problem to take it out? I don't know that it is. So.
Yeah. And, you brought up, speaking of metabolic disorders, and you referred to this a little bit earlier about mitochondrial disorders. It reminded me how those are really difficult to diagnose, or at least with, it was suspected, after a bunch of genetic testing came back inconclusive. And I remember the geneticist saying that because there were 2 or more body parts or that were affected by it, they could suspect a mitochondrial disorder. And I remember that he said there was no way to rule out after that, after having 2 or more body parts affected, there was no way to rule out a mitochondrial disorder, but we could try to confirm it through mitochondrial DNA testing. She did a skin biopsy, and that was never confirmed, but like he said, we couldn't rule it out. I didn't know if you could talk a little bit more about that, like why it's difficult and how they're inherent, why it's difficult to diagnose, and how mitochondrial diseases are inherited, and can they happen spontaneously and things like that.
Yeah, great questions. So first of all, mitochondria are the powerhouse of our cells, and they are very important in our cells. We primarily get the vast majority of our mitochondria from the egg cell that produces us. However, we've recently learned that actually there is some mitochondria that has to get into the embryo from the sperm. And so for a very long time, we thought mitochondrial conditions were primarily inherited from a mom to a child. And so if you saw a mom and all of her kids had the same like neurologic, medically complex, because it can, you can see a variety of symptoms with mitochondrial disorders, including things like muscle weakness. If you see that, then you should suspect mitochondrial disorders. However, as it turns out, we did not know the full story. So within just the last couple of years, they've learned that the sperm does supply some of the mitochondria. And so, and why that's different from other genetic conditions. So usually we inherit our genes in the nucleus, and that comes from, we have 46 chromosomes. We get half of those chromosomes from mom and half from dad, and they form 23 pairs. And there are some mitochondrial genes that reside in the nucleus. But the vast majority of what controls the mitochondria and what they're doing is going to be in the mitochondria themselves. So each mitochondria, and you usually have many mitochondria per cell, but each mitochondria will have its own little circular piece of mitochondrial DNA. And that is inherited completely separately from the nucleus again. So you can in the egg have many mitochondria. You can have the sperm come in and have some mitochondria. Now, when that embryo starts to grow and divide, it doesn't actually divide its mitochondria evenly. And especially when you start getting into tissues that are developing from an embryo. And some tissues are going to be mitochondrial rich tissues like muscle tissues and liver. And some are going to be not as mitochondrial rich. And for example, like the blood cells, and they just don't need as much energy as what a muscle does or what the liver does to process through things. So when you're doing your testing, and traditionally genetic testing is done off of blood draw or cheek swab, we can do skin biopsies. All of those sources, though, are really getting not mitochondrial rich tissues. I mean, yes, there's mitochondria there, but it's not in abundance that you see in muscle cells or that you see in the liver. And of course, like the brain too, like neurologic cells would also have an abundance of those, but we don't want to go like sampling that, right? So, so really, our traditional means of testing are going to be in these tissues that don't have a lot of mitochondria. And if you're talking about a condition where, only a couple of the mitochondria had the mutation from the beginning of the conception, and we're talking about how this has been, these cells have grown and divided and divided and divided, and that can be a little bit dilute, and especially in a tissue where there's not much mitochondria to begin with. Yeah. So the chances that you're going to catch it is, maybe you catch it because it's there and it's present in abundance, but it's possible that a tissue that you're looking at may not actually have that mutation. And just like we've talked about with the nuclear DNA, mutations can arise at different points in development. So it's possible for a mitochondrial mutation to have occurred after conception, somewhere along the embryologic developmental pathway, and it could only be present in a few particular tissues. So sometimes we find that we're better able to pick up on mitochondrial disease by doing biopsies of muscle or biopsy of the liver. And so sometimes if a child is already scheduled for another procedure, then we'll take that sample. It's obviously not a tissue. Either of those options are not easy tissues to get to, and they are invasive procedures. And so we don't want to have to go down that route and putting a child through that if we don't have high suspicion that that could be what's going on. Now, there are ways to suspect mitochondrial disorders through biochemical measurements. So there are certain biochemical markers that we can look for that are indicators for mitochondrial disease. And I think that that's a good initial step. If the symptoms seem like they could go along with mitochondrial disease, then do the biochemical markers. If those look like, okay, yeah, that could be right, then, thinking about best way to get, to the mitochondria for testing is the next question. And in a child that's very medically complex, it's reasonable to start with something like, a blood draw or a cheek swab or a skin biopsy and see if that gives you any answers. But if it doesn't, you still can't say this isn't it. And even after we've biopsied a muscle or we biopsy a liver and we don't have an answer, then we still can't say it's not mitochondria, because maybe it was, again, just escaping the limitations of our testing and the boundaries of our testing. So it's very hard.
And I misspoke. She actually had a muscle biopsy I said skin biopsy, but she did have a muscle biopsy. And that was during another procedure. She had, they were doing something with her kidneys and they went in and took a biopsy from her thigh. But yeah, so I said skin biopsy, but I meant muscle biopsy. Yeah. So,
and sometimes you can even see from that biopsy if there's something different about the mitochondria under a microscope. That can also be a way to detect.
Yeah, I think there were some things that were lower, like, I can't remember, like something was lower, but again, it was like still within, I don't know, it was confusing. Anyway, I just remember it not being conclusive. She started taking coenzyme Q after, but that was like one of those things that it like wouldn't harm her to do it. We don't know how much, I mean, it didn't help, but I know a lot of people with suspected mitochondrial take coenzyme Q, but
Yes, yeah, that's definitely a common experience. And yet, like you said, there's no harm in it. So a lot of
yeah,
physicians feel like we don't have to prove that it's this. If we suspect it, we can just go ahead and try that. And it helps for some families for, for that child, and sometimes it doesn't.
yeah, yeah.
So Erin, we've talked kind of about diagnosis of genetic conditions and the family planning that can go into your counseling, and then also some about treatment of conditions. Are there additional ways in which you might serve a family through genetic counseling?
Yeah, that's a really good question. And genetic counselors do wear many hats. I would say that one of our biggest jobs is to advocate for the family within the medical community. And also within the larger community. And that might mean, within a school or community resources. And so helping connect families with the support resources that they need, helping to educate the providers, the doctors, nurses, therapists that are working with that child about what that condition is and what it means. And maybe even, how can we treat it, or how can we best optimize for this child? So those are things that we do. We also do want to support families from a psychosocial standpoint as well. And so, I recognize that it's hard living in this world regardless, and especially now with COVID, right? So we all have different stressors in our lives, and we all have different thresholds for when stress starts to affect our daily functioning. And I would say that for many of the families that I worked with, that counseling was something that was very important to just coping with everyday life, and finding ways to be proactive with their child and with their child's development, and how to just manage the stress that can go along, or even not stress necessarily from your child, but from how the community and people around your child respond to your child. So therapy in helping families get access to that is very much a part of our role. Helping families get connected with resources that support them from the medical complexity standpoint too. So some families may need extra nursing help. Some families may need medical equipment. Maybe it's not medical equipment. Maybe they need like a stroller that helps accommodate the, all of the stuff that they have to take for their child. So, finding resources for them that meet those needs, that's part of what we do. And I also think that part of our jobs as genetic counselors is to have those hard conversations. And what I mean by that is that sometimes people need help telling their families about a diagnosis and what it means, and answering questions for the family, for maybe teachers or other people that are going to be caring for their child. And so helping families to learn how to communicate around that diagnosis is very much something that we do. And I think that also applies to hard conversations with children as they get older and are asking questions about, what is this that I have? What does it mean? What does the future look like? Can I pass this on to my child? All of those questions are things that we can also help families to answer. And I think another thing I would point out is that many families do have more than one child, and maybe not all of their children have the same neurodevelopmental or medical complexity. And so there are other children who are developmentally typical, maybe asking questions about, can I have a child like this? And what are my chances? And they want answers too. And how do you have those conversations? So that's another part of what we help to supply to families. But again, I think bringing awareness in the community too, that's another part of what we do. And doesn't have to be around a specific case. It can just be in general, and helping people understand just the meaning of genes, and how that relates to our health and to our development.
Yeah, I think all of those are such powerful resources that you're referring to in terms of advocacy and connecting to resources and just general, counseling families. For families that have exhausted their genetic testing and still don't have a diagnosis, and they really want to do, find their ways to further their chances of eventually finding a diagnosis, what options are available to them additionally?
Yeah, Great question. So there is the Undiagnosed Disease Network, which I know that you all are acquainted with, and we do here in St. Louis have access to a local clinic for the UDN now, and that's just happened within the last couple of years. But the UDN is a National Institute of Health program where providers, clinical providers can help families who have kind of, like you said, exhausted their genetics perspective or any other perspective to finding an answer in potential treatments. And they can use research methodologies to help figure out if, testing from that standpoint can be helpful. But that takes a long time in the sense of, you could go in and you could give a sample and you may not know anything for years. It could be that they are, as they discover new genes, they go back to their database of samples and try to check to see if other children who they saw fit that same kind of clinical picture test. You look at the raw data is usually what they're doing and seeing, okay, do we see a mutation here that we didn't know what to do with before? And is that relevant now? And so that can take a very long time. And just like with any research. And I think that is another point, not just the UDN, but there are other research organizations out there that offer whole genome sequencing or other kind of more experimental testing options. And so being maybe open to that kind of an opportunity would potentially hold answers for families in the long run. But again, it could take quite a long time. If you have participated in one of those programs, I always do recommend that families, kind of touch base with that research team every few years just to see, make sure that the routes of communication are still open and understand where they're at in their research process. Some research programs that people participate in, they have the intention to recontact you and tell you what they find. But other research programs, they do not have that expectation. So if you're getting into a research opportunity, make sure you understand which of the two, scenarios that you're getting into. And that way, if it's something that they intend to get back into communication with you about, just check in with them. People's phone numbers change, people's addresses change. And so it could be that by chance they just lose track of you if you're not keeping with them, and letting them know as those routes of communication change for you. So do touch base with them. Banking tissue is another option that some families do go with, and that could be cord blood. It could be regular blood. It can be other tissues that you can bank for future testing. So those are options that are available to families. Some of those are done on a research basis, and some are done on a basis where you pay to have that preserved, and you have to pay, a fee every year or so to keep that sample cryopreserved. So again, when you're going into a scenario, know what you're getting into. Know if it's research and you're actually going to be able to use that tissue when you want. Or, if it's a situation where you're going to be paying, and what happens if down the road, you get into a financial circumstance where you can't pay. What are the options? So those are definitely pieces that I would make sure that people think about and understand. Mm-hmm. If you have done genetic testing, like a whole exome sequencing or a whole genome sequencing where you pay for that out of laboratory, do know that many of those laboratories do offer a free reanalysis, and they do recommend at least 1 to 2 years after that original analysis to wait, and then you get that free reanalysis. So essentially what they're doing is going back and saying, okay, have we discovered any new genes since we did this report the last time that now we can look at and actually make sense of, and is this relevant for this sample for this child? And occasionally technologies do change. So, it is possible that you could go to your doctor one day and they say, oh, we have this really great new test, and would you like to do a sample? And, it has a good chance of giving us an answer, even though you've gone through X number of genetic tests already. So those are all things to do. Stay in contact with your genetics group, with whoever you used for your genetics care, and just touch base with them every 1 to 2 years by phone. You don't have to go in. You can call and say, hey, just wanted to check in, see if we have any new opportunities for testing or new answers that we can seek.
And is that true even after if your child passes away? would it be reasonable for me to call June's geneticist and see if they have any new findings?
Yeah, I think so. And I think one of the questions is, are there any new conditions that might fit, what we knew that she had? And another question would be, if you did do whole exome sequencing, can they go back and do a reanalysis? And like I said, you usually get one free reanalysis. And then after that, that doesn't mean you only get one reanalysis. So, you can use reanalysis after that point, but there may be a fee associated with it. Still, in my experience, that fee is very minimal compared to the original cost of the test. So it could be something like $100 or less, is kind of the picture that I've seen to this point. So ask those questions, see if they have any new information. It doesn't hurt.
Erin, how would a family go about finding a genetic counselor to work with them?
Yeah, so I actually would suggest the first place that a person could go is to find a geneticcounselor.nsgc.org, which is a website that is maintained by the National Society of Genetic Counselors, and you can search by lots of different fields. So you can search by zip code in like certain mile radius. You can search by specialty. But yeah, go ahead and search there and see if you can find a genetic counselor that fits what you're looking for or the area that you're looking for. Alternatively, I would say that there are healthcare systems, many healthcare systems across the country, especially pediatric hospitals or children's hospitals that have genetic staff. So you look at your healthcare system, ask the question to your pediatrician or to your other specialists, who do you refer to for genetics? Who are the professionals within your organization? And then after that, so for different reasons, maybe there are healthcare systems that don't have access to a genetic counselor. There are patients who maybe don't want to use the healthcare system for one reason or another. They don't, lots of reasons why people may not want to use a traditional healthcare system, but there are independent genetic counselors and large genetic counseling organizations that fall outside of healthcare systems. Sometimes insurance companies are contracted with like a telephonic genetic counseling organization. So there's a couple of those across the country. So check with your insurance. And alternatively, there are the independent counselors, like I mentioned, and I do have myself an independent service. So my service is Ingenuity, and it's spelled INGENEUITY. There's also Clover Genetics out of Pittsburgh, I would highly recommend. And then the other company that I would recommend is Find Genetics. And so there's lots of other independent genetic counselors out there. Just Google search, see what's local to you. But many of the independent counselors will offer telephonic or virtual services. So you don't necessarily have to leave the comfort of your home to do that.
And do you need a referral from a pediatrician or a neurologist to access the independent services?
Good question. So many genetic counselors do not require a referral from a physician of any kind. However, sometimes insurance companies will require a referral. So check with your insurance company, or you can call the genetic counselor that you are looking to go to and see if they can help you navigate that process.
Do insurance companies typically cover genetic counseling, or are there many families paying out of pocket for this service?
Good question. So many insurance companies do cover genetic counseling as a service. Some do not. And for the ones that do not, so there are healthcare systems that will offset that cost. Maybe it's that they have a grant program that provides services for free. It's also possible that they may just discount the prices for patients that have to pay out of pocket. So all of those are options. That's another reason why people may seek care at an independent genetic counseling facility, is that oftentimes, they're a little bit more accessible financially, as opposed to a large healthcare system where the fees may be set by the hospital and not necessarily by the counselor. But I would say that by and large, the genetic counseling is something that is covered, or there's programs that help patients to access that at a more reasonable rate.
Great. And do families typically meet with you then on an ongoing basis, or are your questions usually answered within a session or two?
That's a good question too. So everybody's case is going to be a little bit different. So like I mentioned, some families will go through testing and they won't necessarily find an answer. And so for them, it may be a situation where they will come back in to do testing at a later date, but it's not like they have a set schedule for that, right? So they can re-access genetic counseling as questions come up moving forward in their life, or if there's a point in time where they want to revisit testing because new technologies are available. So most families usually will meet pre-test and then post-test. So pre-test to make sure they understand what testing is being done, how it works, the limitations, how to have an opportunity to just hear what it is about and kind of the process. And then after genetic testing, then they would access a genetic counselor again, oftentimes to go through their test results, especially if it's something positive. So if we find a genetic diagnosis, those children may actually need to be monitored more long-term in a genetics facility, usually with a geneticist and a genetic counselor. That's not always the case. So some diagnoses, it's just, oh, okay, this is what it is. There's no medical management or enough of medical management that maybe just like a pediatrician or one of their specialists can help to manage. And then they don't necessarily need to see genetics again. I still do encourage those families usually to follow up by phone every 1 to 2 years so that they know that nothing has changed, or if something does change, they have a route of communication to get that information from a genetics team, because that information may not actually go to their specialist or to their pediatrician. But there are some families where there's a genetic diagnosis that has a very set schedule on medical management and maintenance that needs to be done on an annual basis, or sometimes even more frequently than that. And so for those families, they may be coming into a geneticist and to a genetic counselor to help maintain that medical management, maybe once a year, maybe once every 6 months. So it kind of depends what the diagnosis is, how often you're having to see the genetic counselor.
That's such a good point. One of our community members is wondering, since the patient's DNA isn't going to change, is there a reason to see a genetic counselor on a regular basis? But you raise a couple of really good points on why someone might be coming to see you regularly or every year or two to keep following up.
Yes. Yeah. And so, besides the fact of people having medical diagnoses that have to be managed or maybe should be managed by a genetic counselor, our knowledge changes, like I mentioned earlier. And so if you didn't get answers that you were looking for, it's reasonable at a later time to come in and see if we can give you those answers. And then also testing technologies change over time, and treatment changes over time. So just because you receive a genetic diagnosis right now that doesn't have a treatment that's available, that doesn't mean that 2 years from now, 5 years from now, that we won't have something that's available. So it could be that you're coming in, even though that child's DNA is obviously not changing. Yeah, I think a lot of people have the misconception that genetic counseling is just about genetic testing, but it's not. And I would also say, just because you see a genetic counselor does not obligate you to do genetic testing. So you can utilize a lot of the educational and support services that a genetic counselor has to offer for medically complex kiddos and not necessarily be doing genetic testing, and that's okay. And our job is not to, sell a test or to encourage families necessarily to do testing unless it's right for them, but it's really more to help manage a child who has genetic conditions or could have genetic conditions, and help to empower families to make their own medical decisions. So testing is not right for every family. And I've definitely helped families that chose not to do genetic testing, and that's okay too. So just keeping that in mind, I think that's another misconception that we're here just for testing and that's it. But really there's a lot more that genetic counselors have to offer. And there's no harm in getting information for families.
Erin, you're such a wealth of knowledge, and I really appreciate you sharing that with us in our community today. Thank you so much for being here.
Thanks for having me. I had a great time with our discussion today.
Thank you.
Yeah, thank you, Erin. Thank you so much for devoting time to sharing your knowledge with us for this Navigating Neurological Conditions webinar. I'm sure this information you shared today will be greatly helpful to our families listening. And I know I personally, hearing your expertise and recommendations have helped me. I learned something new with the mitochondrial DNA that's changed, and I'm sure things like that is always changing. So thank you everyone for tuning in. And for questions, please visit us at junejessee.org or reach out to us on our social channels. Thanks.
Thanks, Erin.
Thank you.
Thank you.